Good morning, everyone. A warm welcome to all of you to today's webinar organized by the Society for Health Research and Innovation Academy. We truly appreciate your presence and commitment to continuing professional development with us. Before we begin, let me share a few important points regarding the webinar proceedings with the things that all are familiar by now. The link to join the webinar will be available until 9:50 a.m. and access to the session will close sharp at 9:50 a.m. The late attendees will not be admitted beyond this time. By participating in this program, you can earn 1.5 CPD points. Participants must remain until the end of the session to claim your CPD certificate because the free webinar series strictly adheres to NCPD guidelines. I hope you will keep your microphones and videos turned off throughout the session, and you can ask questions via the chat option at any time. Your queries will be addressed at the end of the session. If you have a very specific question to clarify, you can email us on office330@gmail.com. After the webinar concludes, stay another few minutes and ensure you fill out the Google form provided in the chat box with the post-assessment questions to receive your CPD certificate through email. This form must be submitted before 11 a.m. today. And please recheck your email address before submitting the feedback, as many doctors miss their certificates due to providing incorrect email addresses. Kindly submit the form correctly at the end of the webinar by 11 a.m. today. And please note that you will not be eligible to have the CPD certificate unless you follow the guidelines and answer the post-assessment questions. Moving on to the topic, common cancer involving eyelids. Our resource person today is the acting consultant in orbit and oculoplastic surgeon at the National Hospital called Dr. Nirodha Jayawickrema. She has completed her subspecialty training as a clinical fellow at two prestigious institutions in the United Kingdom, Queen Victoria Hospital, East Grinstead, and Moorfield Eye Hospital, London. Cancer is becoming common worldwide, and hope we can have a timely update on common cancer involving eyelids. Over to you, Dr. Nirodha Jayawickrema, to continue with the session.
Thank you very much, Kanchana. Good morning, everyone, and thank you very much for coming to this session today. I'm Nirodha, as Kanchana introduced me, and I'm an acting consultant in, actually, I'm an ophthalmologist, and I'm trained in the subspecialty in orbit and oculoplastics. So I'll be talking about eyelid malignancies today. My aim today is to kind of give a rough idea on what these common, they're not that common, but they're not that uncommon either. So I just want to let you know about the features of such malignancies, what types are there, and if I can get you to kind of suspect such a malignancy when a patient presents to you with a lesion, knowing the features that can that we can look for to come to a diagnosis. If you get some idea about that, that's my aim today. So I'll talk about types of malignancies, diagnosis, and I'll talk about a bit of management as well. So I'll go into a little bit of depth there. You might feel like it's a little quite targeted for ophthalmologists, but if you're inspiring to become an eye surgeon, that would be helpful for you as well. And then the follow-up and the other things. So when it comes to the lid, the malignancies, we know the malignancies are arising from the cells available there, primary malignancies, unless it's a metastasis. So when it comes to the lid, we do have the skin. So same cancers that involve our skin, the skin of the body, can involve the lids. So we have, when it comes to the epidermis, we have the basal cells, the melanocytes, and the squamous cells. So in this part of the world, the squamous cell carcinomas are quite common, and then melanomas are also there. Basal cell carcinomas are said to be not that common in this part of the world, but let's see, it's not that uncommon. And then when it comes to the lid, it's not just skin. So we have other structures. So this is a cross section of the lid. So we have the skin here. This is the upper lid. So we have the skin here. And then underneath the skin, we have the orbicularis oculi muscle, the muscle we are using to close the eyelid. And then at the same plane, we have the lashes, and the lashes have glands of Zeiss. They are oil glands. And then we have fat. We have the tarsal plate. The tarsal plate is the one which is giving a bit of a character to the lid. That's why we cannot pinch the lid easily. So the tarsal plate is formed of a bit of fibrous tissue, but inside of it, we have the meibomian glands. The meibomian glands, the culprit which causes the styes, the chalazions, and the meibomian glands can give rise to oil gland carcinomas. So we call them the sebaceous gland carcinomas. So we have the levator muscle here. It's connecting to the tarsal plate. And then we have the conjunctiva lining the whole surface here, the fornix, and we have lacrimal glands around here. And then the eye. So these structures can give rise to cancers as well. So the risk factors, the general risk factors, I'll talk about general risk factors. So we think since we have a bit of melanin, we are protected. So back in the days, the skin, even still, we categorize the skin according to the presence of melanin. We call it the Fitzpatrick scale. So we think when the skin is light, Fitzpatrick type 1 skin is more prone to get cancers. We think we have protection because we have melanin, but it's not the case. I'm working at the National Hospital Goal at the moment. It's really sad to say we have at least one patient coming to our clinics every week with a cancer that needs surgical excision. So that's just one clinic, and I'm still starting my practice here. So the skin cancers are not that rare, lid cancers. So the sun protection is a must. Then the features. What do you have to look for? So when a patient comes with a little lesion in the eyelids, they may say, oh, there's a lesion in my lid. It has been there for the last couple of months, or sometimes it can be years. And now it's sometimes they may come and say, it started to bleed. Sometimes they may say it's completely asymptomatic, nothing is happening, but it's starting to get bigger in size. So recent onset enlargement, recent onset lesion, which is kind of enlarging in size over like a span of couple of weeks. That's a sign that it could be a malignancy. Then if you look closely, you may see the lash loss. So lash loss is a very good sign to kind of identify something sinister going on underneath the skin, because if there's a destructive process going on, it tends to make the lashes fall off. Usually that's a very good demarcating line when it comes to identifying lesions in the lid margin to see whether they are malignant or not. But this is just this is also a bit of an arbitrary thing, because some lesions can, if they're presenting early, the lashes can be there. But if you see lash loss, that's kind of a good sign that we can kind of think of this as malignancy. Then the other thing, if you see any destruction, evidence of bleeding, contact bleeding, they are signs of a malignancy. Then the common types we come across, there are many other types, but these are the 4 common types we come across: basal cell carcinomas, squamous cell carcinomas, sebaceous carcinomas, malignant melanomas. If you have any questions, you can raise it during the presentation. So basal cell carcinomas. Basal cell carcinomas are not considered common in this part of the world, but that's the commonest eyelid malignancy in the world, because it's commoner in the western part of the world, because the type of skin is considered as one of the risk factors. But sadly, it's not that uncommon. I have one patient at the moment in my ward with a basal cell carcinoma. I wanted to highlight this because we think it's not common. So we don't think of it when we see a patient. and we think it's just a lesion because I have run a case series about basal cell carcinomas in pigmented skins. In pigmented skins, the commonest type is there are different types of basal cell carcinoma. The commonest type is the nodular basal cell carcinoma. It's not a very aggressive tumor. So it's a very slow growing tumor. Even in other countries, when you are diagnosed with a nodular basal cell carcinoma, you don't get the resection date for like 6 to 7 months because it's not an aggressive tumor. But it can spread in and around that area, and it can cause destruction to the tissues. It's not metastasizing, but it can cause destruction, and if it gets bigger, the reconstruction becomes challenging. So we have to think of this possibility when we see a lesion. So it's when we see the patient, it might not have caused any bleeding or lash loss, but the lesion is there, slowly growing over a few months or few years. So it's commonly located in the medial canthal area, lower eyelid, and sometimes the upper eyelid. Metastasis is extremely low. So you can see by the percentage. So when you're looking at the lesion, this is the typical lesion, how it's been described in books. Raised edges, pearly white color, and it can have a bit of central ulceration, bleeding, and you can see small blood vessels, we call them telangiectasias, running on the surface. This is a typical basal cell carcinoma. But in pigmented skin, it can vary. I'll show a little picture. This is one of the patients who was in my series. Look at this lesion. It's quite widespread, and it was misdiagnosed at first. And this was a basal cell carcinoma. So the risk factors, as I told you, usually the light skin, Fitzpatrick type 1 skin is considered as a major risk. Blue-eyed, red-haired, blonde. That's a category that is being recognized as having high risk. And then middle-aged, elderly, in the sense, prolonged sun exposure is one of the main risks. So if you have prolonged sun exposure during the first 2 decades of life, if you have that kind of a skin type, you are prone to get basal cell carcinomas. But as I said, even if we have pigmented skin, we can get. And then cigarette smoking is another known risk factor. And the other thing we've noticed is if you get a basal cell carcinoma, you have high probability of developing additional skin cancers because you've had sun exposure likely and related damages to the skin. And there are syndromes that are associated with basal cell carcinomas, basal cell Nemeth syndrome, Golin-Gott syndrome. It's uncommon, autosomal dominant, and they can get multiple basal cell carcinomas. And then also xeroderma pigmentosum, because the sun damage repair mechanism is faulty in them. So there are several different types of basal cell carcinomas, combinations of types. So you can get nodular. Nodular is the commonest and less sinister type. If you get good clearance with a surgical excision, it's quite less likely to come back. But other types, morphiform, infiltrative types, even if you get a good clearance, even if they don't metastasize, sometimes they can come back at the same spot where the lesion was. So we have to follow them up a little longer. If the patient was diagnosed with nodular basal cell carcinoma, we usually follow them up 6 monthly for 1 year and then yearly for 3 years in total. And that's it. Then we ask them to assess the area by themselves and to look for any other lesions. And for infiltrative and morphiform types, more infiltrative types, we have to follow them up for 5 years at least because they can come up and earlier we diagnose it, we can excise and get a clearance. The tricky thing about cancers around the eye is the eyelid is quite important for us to protect the eye. So when there's a lesion, it's kind of distorting the whole structure and it's going to affect the lid closure. So if the lid closure is affected, it can give rise to dry eyes and it can cause ulcerations on the surface of the eye. And even when we do surgical excision, we have to make sure that the reconstruction is done properly So we get the proper anatomy back, plus the functionality of the lids back. That's why the oculoplastics has become a separate subspecialty handling these issues. So smaller the lesion is, better the outcome. So early diagnosis is quite important. Then the management is usually surgical. So we excise and reconstruct, but reconstruction is delayed until we receive the margin clearance. So frozen section, whenever it's available, that's one of the best methods. We remove the lesion, we mark the edges, takes little slivers from the edges and send them off to be tested then and there. So within half an hour or 1 hour, we get the results. If we have reached the clearance, then we can reconstruct it then and there. So the risk of eye exposure, because when we remove a chunk of the lid, if we have to wait for 1 week for the results to be received, the patient has to take care of the eye. So if we get the results then and there on the day, then we can reconstruct the lid then and there. So the risk of exposure and eye injury is less. Then the other method is Mohs micrographic surgery, usually done by the dermatologist. They remove the lesion and check the margins then and there, and then send the patient over to us the next day or the day after for the reconstruction. Then the lesion can extend into the orbit very rarely. It's not uncommon though. If that's the case, the thing is we have to remove structures that are involved, but the things inside the orbit, even fat tissue, is there for a reason. So it's better to identify these lesions before they go into the orbit. When the orbital tissues are involved in an extensive manner, sometimes we have to go for orbital accentration. If we feel like removing certain structures are not going to help the patient, because if we remove muscles and nerves, the eye is not going to work. So rather than going for that, sometimes we have to go for orbital accentration. So nowadays, the scientists and the doctors have started to come up with new medicines, immunotherapy, to avoid that situation. Especially there in cases of squamous cell carcinoma and sebaceous carcinoma. They are very aggressive. They can involve the orbit. And patients with systemic syndromes like Golin-Gott syndrome, who cannot kind of get rid of the cancers just by getting them excised, as they get cancers all over the body, basal cell carcinomas all over the body, they have come up with immunotherapy. So vismodegib, it targets the sonic hedgehog pathway. This is a bit of a deep, kind of a bit of an advanced thing, and they are working quite well for such patients, and this can be vision saving and eye saving. And other types are there as well, zonidegib. And topical imiquimod is used for superficial basal cell carcinomas if needed. So the studies have shown 45% response with vismodegib. So there's hope now. And then let's talk about squamous cell carcinoma. This is one of the common types we see in Sri Lanka. Though it's 5 to 10% of eyelid malignancies. They can arise spontaneously, or it can arise in area of solar injury or actinic keratosis. And it is potentiated by immunodeficiency. When we see a patient with squamous cell carcinoma, we have to think of that too. So squamous cell carcinomas, they tend to be a bit aggressive looking, rather comparing to the basal cell carcinomas. Similar appearance sometimes, raised edge with ulceration. What happens is when the cancer is growing aggressively, the central part breaks down and it starts bleeding. So the patient will say there's contact bleeding. And the other thing is squamous cell carcinoma can affect the ocular surface as well. It's an ocular surface squamous cell carcinoma. So similar to basal cell carcinoma, it's commonest in the lower lids and the medial canthal area, and they can metastasize. So it can involve the lymph nodes, and it can go through the lymphatics and bloodstream both. So when a patient comes with a lesion like this, we have to make sure that it has not caused any metastasizing lesions. We have to do the scans, MRI scans and ultrasound scans of the head and neck to check for any lymph node mets, and then systemic evaluation to check for systemic meds. Then the risk factors, the main thing is sun exposure. So when a patient comes to you with such a lesion, ask for sun exposure, patients who are people who are working in sun all the time. Irradiation, if a patient has had treatment in that area, immunosuppression, chronic inflammation, and again, xeroderma pigmentosum like head, which is extremely rare. Then again, the management is mainly excision, as I told you, for basal cell carcinomas. And in squamous cell carcinoma, though, we can treat with cryotherapy for the margins. It kills the cells in the margins and it reduces the risk of recurrence. Then again, immunotherapy is coming up for squamous cell carcinomas. Cemiplimab is a PD-1 inhibitor, and then cetuximab, EGFR inhibitors. This is for the disease that is not amenable for surgical excision, because and then topical treatment is also there, because when it comes to the eye, when the patient comes to us, the other eye may not be a seeing eye. The eye affected may be the only eye, and if there's orbital disease, we should have a way to protect the eye, preserve the eye. So this patient was from my cemiplimab study, the last study I conducted as during my foreign training. We checked the efficacy of cemiplimab as immunotherapy for patients with orbital squamous cell carcinoma and with localized metastasis. So this patient came with orbital involvement. This is his only eye. The other eye's vision is 636 because he had a macular hole, some anatomical change inside the eye, which cannot be treated properly. So this eye is his only eye, and there's a huge lesion in the medial canthal area, which is quite tricky to remove, plus a local metastasis on the forehead. And he was happy to go ahead and use cemiplimab and see how things would go. So he was in the trial, and this is how he was after 7 cycles. Every 3 weeks, he received the cemiplimab infusion, and this is after 7 weeks. He is still managing. The lesions have gone down considerably in size. You can't even see where the metastasis was, and the orbital lesion is well controlled, and he's still receiving the cycles. So that's about squamous cell carcinomas. Then sebaceous cell carcinoma. This is arising from the oil glands around the eye. As I showed you when I was talking about the cross-section, the meibomian glands, the C's glands around the eyelashes, and the caruncle where the sebaceous glands are there. And skin of the eyebrow, it has a lot of sebaceous glands. So it can arise from these areas. It's oftenly common in the upper lid area because we have more meibomian glands in the upper lid. Around twice the amount of glands we have in the lower lid. So the sebaceous cell carcinoma, I want to talk to you about this because it can mimic blepharitis. I hope you know what blepharitis is. We usually call blepharitis when there's redness in the skin around the eyelids, when patients come with dry eyes. When we look at the eyelids, we see a bit of redness and inflammation. This is sebaceous cell carcinoma. It has not caused any lash loss yet. It's just redness, but it's spreading along the length of the lid. So if a patient comes with this kind of a lesion, we can't just say, oh, it's blepharitis. If it has been going on for a while and not responding to treatment, we have to think of possible underlying cancer like this. And sometimes it may mimic a chalazion because it's arising from the same area. Chalazion is a blocked meibomian gland where the oil is collecting inside of it. Sebaceous cell carcinoma of the meibomian gland is growing in the same area, so it can look like a chalazion. We have come across patients who have undergone chalazion drainage a couple of times, not going away, coming to us, and then when we do a biopsy, proven as sebaceous cell carcinoma. So when a patient comes with a non-resolving chalazion, think of this. Think of the age as well. Older patients coming with such symptoms, think of a sebaceous cell carcinoma as well. And make sure if you want to drain, try to do a biopsy at the same time. You can take the biopsy from the tarsal side and from the edge of the edge of the lid as well. The risk factors, old age is the main risk factor. Radiotherapy, immunosuppression, and there's another syndrome called Moore syndrome. They can get cancers in sebaceous glands. So if a sebaceous carcinoma is found in a younger patient, better to go for genetical study as well. Then the hallmark feature, there's phagocytoid spread. It can spread along the conjunctiva without causing any changes that we can see. So when we see a sebaceous carcinoma, usually when we do the biopsy or excision, we take samples from around the conjunctiva to see whether it has spreaded onto the surface. It's a very nasty cancer. It can be here, but it can be spreaded to this area. So it can be affecting the whole surface of the eye. So when it comes to treatment, we might have to remove the eye and go for an excision. It is usually very aggressive. Plus, it can cause systemic metastasis as well. So we call it a mapping biopsy. We draw a picture of the eye and we take samples from each and every area of the eye. Then again, management, the main management method is surgical excision. Then age appropriately, we have to do cancer screening and genetic workup for motor. Then during the surgical excision, we can again use topical mitomycin or cryotherapy for positive conjunctival margins. If you want to preserve certain important structures in the eyelid, we can try this and see whether it has controlled the spread. Then again, targeted immunotherapy is coming up because sebaceous carcinomas are more common in this part of the world. This is the last type of cancer immunotherapy is tried for, but they are trying to use cemiplimab and pembrolizumab for this at the moment, and it is being currently studied. There's a patient who came to me around 3 weeks back. History of like 3 weeks history of a lesion which is growing, and these look like little cysts actually. And if you can see, there was no lash loss. Lashes were still there. Look at this area. Lashes were still there. And this was proven to be a sebaceous gland carcinoma. Initially, I took an incisional biopsy, sent it off, and it came out as a sebaceous gland carcinoma. Then we did a wide local excision, which cleared the lesion, but there was a little bit of the margin. We usually we usually go for a good clearance when it comes to the margin. If the lesion is there, we try to get a skin clearance of at least 2 to 3 millimeters from the edge of the lesion, visible lesion, and the microscopically visible lesion. So the superior margin clearance was not adequate. So I went for a further excision, and at the same time went for reconstruction. So when it comes to a gap like this in the upper lid, it's completely affecting the lid closure. So he had enough skin laxity, so I could repair it with a bit of releasing of the lateral canthus. And this is him after about a couple of weeks from the reconstruction. Then malignant melanoma. It's less than 1% of all cutaneous malignant melanomas for the lids, but it can cause metastasis, and it's a very aggressive disease, and it can be missed because it can be identified as a small nevus. So the risk factors, again, sun exposure, genetic predisposition. So they usually have variable pigmentation and irregular borders. They can ulcerate and bleed. And there are 4 clinical pathological forms: lentigo maligna melanoma, nodular, superficial spreading, and acrolentigenous. This area, it looks like a lentigo maligna melanoma. And this is a melanoma. It's quite hard to even see. Just imagine this on our skin. It's quite difficult to identify. the image is not. And then this condition called nevus of Otta. People are born with this, a little birthmark-like thing involving the lids and the surface of the eye. They are prone to get choroidal melanomas and malignant melanomas of the eyelid. So they have to be regularly assessed for this. Then the management again, surgical excision with wide margins. But when it comes to melanomas, it's a little tricky because we can't do frozen sections because of the pigmented cells are not very, they're not giving a very good margin clearance evidence on H&E stains. But there's a new immunostaining called MART1 that can be used for frozen sections now. Because of that issue, the paraffin-embedded sections, wide local excision with delayed reconstruction is the gold standard at the moment. And targeted immunotherapy is also coming up, vimurafenib. So hope is there now. So what you should do, if you're suspecting a lesion to be a malignancy, if you can, refer immediately. Sometimes the patients, due to social reasons, they don't wish to be referred. If that's the case, arrange for an incisional biopsy, but take a photograph before you do anything to the lesion. This is quite important because sometimes we receive patients after the lesion is removed by somebody else, and we can't even see where the lesion is, and the margins are not marked properly at the initial excision. Even if it's sent for biopsy, histopathological assessment, if we can't see where the lesion was, then we have to guess and remove tissue where the lesion might not have been there. So it becomes quite tricky for us to manage it. Then we'll have to wait until the lesion comes back to treat. So take a photograph. All of us have phones with cameras. Take a photograph and document it, and draw a little drawing as well. Draw a little sketch and draw it. If you can measure, because TNM staging, though we don't talk about it much in eyelid cancers, it's quite important when it comes to if it kind of spreads to the rest of the body. So for the TNM staging, it's quite important to have the measurements when the patient presented, how big the lesion was. It's quite important. So do a drawing and take a photograph. Take an incisional biopsy, so you know you are dealing with, then you can confirm whether you are dealing with a malignancy or not. And then if sadly, if the suspected diagnosis is correct, then educate the patient and immediately refer for specialized management. So after this talk, if you can suspect of a malignancy, if there are risk factors and if there are suggestive features, that was my aim. And then because the early detection and proper management can save sight and also life of a patient. And it's quite tricky when it comes to lid malignancies because we have to reconstruct it properly to protect the eye. That's why I wanted to talk about this topic today. Thank you.
Thank you, Dr. Nirodha, the acting consultant in orbit and oculoplastic surgeon at the National Hospital Galle, for that informative lecture. And actually, this is an area that we usually tend to overlook in our training programs. So I hope it made all of us to think widely about the lumps around the eyelid. So we have received few questions, and Madam, the first one is, Madam, actually, you described that the long-term sun exposure within the first 2 decades of life is a risk factor for basal cell carcinoma. So what about our students who are engaged in our outdoor sports, and how should we advise them to get protected from skin cancers?
Using sun protection is the main thing, because back in the days, the generation we see these days, they didn't have access. I mean, there was no SPF included sun protection creams back in the days, and it was not big in Sri Lanka. We thought melanin is protecting us, and it's not going to happen to us. It used to be a first class. It used to be a problem which was affecting the white skinned people back in the day. So, but now we know it's not uncommon, and we see a lot of patients in their 70s and 80s coming with lid cancers. So use sun protection all the time. And it's good for your eyes to wear sunglasses as well. If you can't apply the cream around the eye, wear sunglasses. But when you're playing sports, if you are swimming, if you are working outdoors, wear sun protection. For Sri Lanka, SPF 50 plus sun protection. I'm not leaving after after I started doing this subspecialty. I'm not leaving the house without sun protection, to be honest. And wear a cap or a hat when you're outside. Um, that's the best thing I can say, because we are quite close to the equator. We have a lot of we have risk of sun damage. So please, that's because we see patients when I was in the UK, white skin people who used to live in Australia are quite prone to skin cancers. Even young people who were born in Australia coming back to UK during their second decade are coming up, like they come to us with cancers in their second decade, the second, third decades of their lives. So sun exposure is the main culprit.
Okay, thank you, madam. And we have doctors working in peripheries. So, madam, what are the alarming signs that we should urgently refer when a person presented with a lump on the eyelids or around the eyelids?
So if the patient says they've been treated for the lesion for quite some times and it's not going away, that's one sign, because Sri Lankan patients do go to doctors. They don't just, even to their family doctor, they do go to doctors and try to get some help. That's one sign. And when you're looking at it, and if they do have risk factors, of course. And when you look at it, when I was emphasizing on the lash loss, bleeding, signs of like crusting on the surface with previous signs of like previous bleeding. Those are like telltale signs that this can be a malignancy. And if you see any structural change in the area, if the lid looks changed, if it's pulled to one side or adhered to deep structures, that's a sign of malignancy. And even if those signs are not there, if you feel like, if you get a bit of a hunch that this could be a malignancy, don't think twice. Send them to us or arrange a biopsy yourself. You can do a small incision biopsy in your hospitals if you have facilities to get the histology done. And then if the diagnosis is confirmed, then send to us. But always document what you see.
The other question is, madam, the risk of recurrence of these eyelid cancers is common or not?
As I said, squamous cell carcinomas and sebaceous cell carcinomas, they can recur usually, because even if we get margin clearance, according to the histopathology, they can recur if we so we have to follow them up quite regularly. As I said, sebaceous cell carcinomas can spread to normal looking conjunctival area as well. We are just taking samples and see. That's all we can do. But it could have metastasized to regional areas. So we have to keep an eye on them quite regularly. When it comes to basal cell carcinoma, infiltrative types, yes, they can. And nodular type, quite uncommon to come back. But we usually follow them up for 3 years to see whether it's coming back. The rest of the basal cell carcinomas, we follow them up for 5 years. For squamous and sebaceous cell carcinomas, we have to follow them up after, if we get good clearance, we have to follow them up at least for 5 years. But we always keep them under our care, at least looking at the eye every year also. And I can see one question: can cancers metastasize to eyelid? Yes, of course they can. And they can metastasize to the inside of the eye as well, eyeball. We can get mets in the retina. Lung cancers and breast cancers, they can metastasize to orbit. So it can get affected. Yes.
Okay, madam. Thank you very much then for your informative presentation on common cancer involving eyelids. And we had more than 500 doctors in today's session, and your expertise has given all of us a good understanding of common cancers involving eyelids. So your dedication and sharing your knowledge with us is greatly appreciated. And also to all our participants, thank you for joining today's stream program. And as mentioned earlier, the link for feedback and post-assessment questions is now available in the chat box. Kindly take a few minutes, provide your feedback, and complete the post-assessment to receive your e-certificates within the coming week. Otherwise, you will not be eligible to have the CPD certificate. The SRI program will continue next Sunday as well with another relevant clinical topic. We warmly invite you to join us once again for another productive session. Thank you, Dr. Nirodha Jayawickrema, the acting consultant in orbit and oculoplastic surgeon at the National Hospital Gold, for your time and for sharing your expertise. And thank you to all our doctors who participated today. We look forward to seeing you again next Sunday morning. Thank you and have a nice day.
Thank you.